All right. Uh, Good afternoon, everyone. Thank you for joining today's session about the abdominal system. The session will be recording, so I hope that's fine with everyone. And let's get started. So the learning outcomes for today's session is a focus history taking, which will be on abdominal pain. And then we'll discuss the abdominal system examination and a rectal examination. So starting with the history of abdominal pain, someone comes and I'm sure you're familiar with Socrates. That's what you'll use to get a bit more history about the pain. So you start with site. So which quadrant or region of the abdomen is the pain in? Is it acute or chronic? The character of the pain, is it sharp? Is it more crampy? Does the pain radiate anywhere? So if you're thinking of GI pathology, so you want to know if it's radiating particularly to the shoulders, to the back, or the groin. Are there any associated symptoms? So is there any fever, any weight changes, either up or down, nausea, vomiting, any hematemesis, or any bleeding from the back passage? You want to know the timing as well. So is the pain constant? Is it always there, or does it come and go? Have they tried anything to relieve the pain? So any medications or anything else? Or is there anything that makes the pain particularly worse? And the last thing you want to say is on a scale of 1 to 10, with 10 being the worst amount of pain, how would you rate this one? It's always good to compare as well. So if they say it's an 8 right now, ask them, was it an 8 when the pain started, or has it been gradually getting worse? So, can you guys think of any other things that we should ask in the history, really in terms of like other systems that we should explore? You guys can just open your chat box and put in some answers. So there are no, yeah, so gynae, that's good. So last menstrual period. Anything else? So it's always good to explore all the systems, but sometimes you may not have the time. So like you guys have correctly pointed out. So you're going to the GI system if you already haven't explored it, but the bowel habits, so is there any constipation, any diarrhea, any bleeding mucus, urinary changes? So this could be any infective changes, so any painful urination, blood, or storage things, so any frequency or nighttime symptoms, and gynecological history. So that's quite important. So the last menstrual period, could they be pregnant? Is there any discharge or pain? And then lastly, once you've done your history of presenting complaint, you just go through the rest of the bits. So the medical history, surgical, drugs, including any allergies, family history, the social history. So some things to focus on would be smoking, alcohol, any recreational drugs, the diet. So fatty foods might link you to certain diagnoses. And then travel history as well can be relevant. And always do eyes so you know what the patient's concerns are. So if someone who's 38 years old comes to the ED with sudden onset sharp pain in the right upper quadrant, it's not a lot of information, but based on this, can you guys think of any differentials, so any particular causes? Or what particular organs would you be thinking about? Yeah, so biliary colic's a good one. So you'd be focusing on the liver or the gallbladder, possibly the pancreas. So if we change the situation and now we see someone who's 17 years old and she's a female, she comes in with sudden onset pain in the right lower quadrant. What are you going to think about now? Yeah, so ectopic pregnancy. So if you see a female of childbearing age, you should always consider pregnancy and you should always rule it out, even if the patient says they're not pregnant. The point of including that is that when you take a history, in particular an abdominal history, it can point you to a good set of diagnosis to start off with. And the age, the gender, the location, and the type of pain are all clues as to what could be going on. it's important to remember that each case is different, so it may not always fit the textbook picture, but it's always a good place to start. Right, that was a quick introduction on the history bit of it. Let's go into examination. So you start with hand hygiene, plus minus PPE. PPE because in terms of COVID, you may be required to wear an apron and gloves, even if you're just doing a normal examination. Introduce yourself, check your patient's details, explain the examination, request them to expose themselves adequately. So you want to be able to see their chest and their abdomen and lie them at an angle of 45 degrees. Once you've done that, you want to begin inspection. So you're going to, first of all, inspect the surroundings, and then you're going to inspect the patient. In terms of the surroundings, if you're doing a gastro examination, what kind of things would you be looking out for? Yeah, nutritional supplements, good. IV fluids, yeah, possibly. What if it's more like, let's say, a GP setting? Or, yeah, sick balls, that's good. Stomas, yeah, perfect. So you guys are naming all the things that you should look out for, particularly in a gastrointestinal exam. So look out for any catheters. If you do see any vomit bowls, sick bowls, offer to examine its contents in an OSCE exam. Look out for stoma bags, any feeding tubes, mobility aids frames. That doesn't directly correlate with GI, but it plays into how the patient's general well-being and their recovery, and other things like fluid balance charts or prescription charts. So anything you see you want to mention. Once you've inspected the surroundings, you want to then inspect the patient. And there are a few things you're going to do. So first, you're going to observe them from a distance. And then you're going to go examine their hand, inspect the hands and arms, move up to their face, go to the neck, the chest, and abdomen. So that's the order I like to do it in, because then you can, work your way from the hands all the way up to the face and go back down to the abdomen. When you observe from the distance, you want to see, are they generally looking comfortable? Do they look confused? Can you see any visible scars or masses? Is their abdomen distended at all? Any yellowings? Can you see any visible jaundice or any hyperpigmentation? During an OSCE exam, so once you've introduced yourself and done the basics, so it's good to say, I'm taking a step back to observe the patient and the surroundings. And that's when you can go through the last two slides we went through. So coming down to inspection of the hand, so this is where it's getting a bit more focused. We're going to check pallor. So if you see any pallor, you're thinking, is there any underlying anemia? That could particularly link to any malignancies, any GI bleeding, malnutrition. Looking for any palmar erythema. It is a normal finding in pregnancy, but if it's not a patient who's pregnant, you're thinking, could it be chronic liver disease? Do you guys have any idea what this picture shows? Yeah, Dupuytren's contracture, that's great. Yeah, so there are many reasons why someone can have a Dupuytren's contracture. Commonly, it could be if they're male, if they have diabetes or excessive alcohol intake. So there are many risk factors, but it's good to identify. That's a good first step. And then clubbing. So in terms of assessing for clubbing, you want the patient to put both the index fingers together, like in this picture, and then you want to observe for a diamond-shaped window. If you do see a window, that would mean there's no clubbing, and then that's all you have to say. However, if the window is absent and you suspect clubbing, then that's how it looked like. Can you guys think of any gastrointestinal causes of clubbing? Yeah, good. So IBD is one of them. So there can be quite a few causes, to be honest, but IBD is a good one to know. Celiac disease, malignancies, and liver cirrhosis can also cause clubbing. Okay, so now I've got a question for you guys. Mr. X visits the GP to discuss his blood results, which show iron deficiency anemia. What nail changes can be observed in this picture? Just pop in the letter that you think is correct. Okay, oh my God, you guys are doing really well. Yeah, so the answer is E. So spoon-shaped nails. Um, Bow lines are something that are more deep and grooved, and you see them more in chemotherapy patients. Paronychia is more infection, so you see inflammation around the skin. Oncolysis is detachment of the nail beds from nails, and leukonychia is whitening of the nail bed. So this is one of the nail signs you look out for when you're inspecting the hands, koilonychia. The other one is leukonychia. So on taking a history from a patient on the ward, you notice that they have leukonychia. Which of the following is it associated with? Okay, yeah. So that's right. So the correct answer is A. Um, it's important to know that this can be a normal finding. It doesn't indicate something. But if you are thinking of an underlying pathology, things to think about are liver failure, protein losing enteropathy, nephrotic syndromes, anything related to hypoalbuminemia. And it's good to know what the nail signs stand for because sometimes they can ask you that in OSCEs. Okay. Once you've examined the hands and you've had a look at the nails, then you want to check for any flapping tremor. So before we go through how to check it, what do you guys think is the most likely cause for asterixis related to the gastrointestinal system? Okay. Yeah, so hepatic encephalopathy is one to remember. The other one could also be uremia, secondary to renal failure. To check this, essentially, you want to ask the patient to stretch the hands outwards like the picture, and then bring their wrist joints backwards and observe them for 30 seconds. If they remain like that, they might shake a little because it can be uncomfortable, but as long as they remain like that, then that's normal, there's no flap. However, if they are upright and then suddenly the wrist falls, and then it might go back up and then fall, and that's intermittent flapping, and that would indicate asterixis. Lastly, you want to check the temperature of the hands and you want to check the heart rate. So you check it for 15 seconds, multiplied by 4. Also comment on whether it's regular or irregular as well. Okay. Once you've examined the hands, you want to move on to the patient's face. So you'll start with the eyes. So what do you guys think is A? Yeah, conjunctival pallor, that's great. And what about B? Yeah, so if B is scleral jaundice, let's go on to C. Yeah, so C is something that you'd see in Wilson's disease, in this case, Fisher rings. So they're quite prominent to see. And what about D and E? Right, so yeah, so D is corneal arcus and E is xanthelasma. And I put D and E together down below because both could possibly indicate hypercholesterolemia. So these are the common things that you want to look out for when you examine the eyes. Then you move on to examining the mouth. So you want to see if there's any oral candidiasis. You want to look out for any glossitis, any angular stomatitis, and aphthous ulcers. So those are the common things that you would say, but in general, you want to look at the general hygiene as well and just make sure everything's fine. Okay, so now we've inspected the surroundings, we inspected the patient, did the hands, moved up to their face, and we're going down to the neck. So in the neck, the main thing you want to do is you want to palpate for Verco's lymph node, which is in the left supraclavicular fossa. So what do you guys think is the significance of palpating the Verco's node? Yeah. So basically, if it's enlarged, it could be a sign of any metastatic intra-abdominal malignancy. And that's why you want to palpate that lymph node. You can also check the right side as well, but it's the left one that we're more concerned about in the gastrointestinal system. Okay, now that you've examined the chest, you come down to, you examine the neck, you come down to the chest. So there are three main things you want to look for. Spider nevi, and that's an important one to mention. So if it's more than 5, it's considered abnormal, and you think about things like liver cirrhosis. It can be normal if a woman is taking a combined oral contraceptive or if they're pregnant. Other things you look out for is any gynecomastia, so which either could be due to a pathology such as cirrhosis or medications like spironolactone or digoxin, and hair loss. So just see the normal pattern, is there any abnormal patches of hair loss. Once you've inspected the chest, you want to lie the patient flat to carry on your abdominal examination. But it's important to warn the patient that the next part of the examination requires them to lie down and check if they can tolerate it and they're happy with it. So the last bit of inspection is inspecting the abdomen. So you're looking for any abdominal distension. There's usually this thing called 6 Fs, which are sort of like reasons for why the abdomen could be distended. Can you guys think of any of these Fs, why the reasons why the abdomen would be distended? Yeah, so flatus is one of them. That's good. Fetus, perfect. Yep. Okay. Yeah. So flatus, fetus, fat, fluid, feces, or any fulminant mass or any mass. Yeah. So if you do see someone with abdominal distension, even there can be loads of reasons, but remembering 6 Fs is a good way to start to rule in and rule out certain diagnoses. Okay. Can you guys think of what this picture might be? Yep, that's perfect. So this is Caput's medusae. And then there's no picture, but yeah, you want to look out and see if there's any visible masses. And what do you guys think this picture is? Yeah, striae, so look out for any stretch marks. And then these A and B are particular signs. So what do you guys think A is? Okay, so basically you're looking for any abdominal bruising, but in particular, A would be Cullen's. So usually how I remember it is if it's central, think Cullen's, so C and C, and B could be Great Turner. So this is more on the flanks, on the side. And both you'd be thinking could be pancreatitis, could be any retroperitoneal hemorrhage. But yeah, so that's what you'd be thinking about if you see any bruising. And lastly, you want to check for any scars. So it might be challenging to remember all the names of scars, but as long as you can see that there is a scar, you can ask the patient, I can notice that you have a scar, can you tell me what it was about? And that would give you all the information you need to know. Okay. So yeah, the other things you might see also in examining them is a stoma. And if you do, there are a few things you want to make sure you know. So sites, it's good to comment what side is it on. Is it in the upper quadrant, lower quadrant? Is it on the right or the left side? The contents, so is it stool? And if there's stool, is it liquid or solid? Or if it's urine? And is it spout, yes or no? So You can see this is an example of an ileostomy and its spout. And colostomies are usually flush. But this is only an extra bit added in case you do see a stoma. So it's nice to always mention that you would examine a little bit about it. Okay. So now that we finished the entire inspection bit, we move on to palpation. Before palpating, always ask the patient, are they in any pain? And if they are, then try and start from the opposite end. So the things you want to do is you're going to do a light and deep palpation, and that would be all over your abdomen. And then you want to specifically have a feel of the liver, the spleen, aorta, and the kidneys as well. So light and deep palpation. When you are palpating them, make sure to observe the patient's face throughout palpation, and you're looking for any signs of pain or discomfort. So sometimes patients might feel the pain, but they may not say it, and you can notice it on their face. Light and deep, so you can see the difference in light. It's quite gentle. It's literally just a bit more than tapping the chest. So you're going to put slight pressure, as opposed to deep, where you can see you put quite a bit of pressure to actually have a feel of the tummy. The places to palpate are the 9 quadrants. And during an OSCE examination, it's good to mention which quadrant you are palpating. If you've mentioned it once for light palpation, you don't need to say it again for deep. You can just say you're palpating the 9 quadrants again. Things to look out for is you're looking for any tenderness, so any rebound tenderness. So if you're pressing and then you remove your hand and then it's quite painful, any guarding, or any masses. If you do suspect a mass, or you do feel a mass somewhere in the abdomen, try and comment on where exactly it's located, if you can see its shape, size possibly. Is it mobile or not? Consistency, and is it pulsatile? So I've got a question for you guys. On examination of a 22-year-old male, you notice pain in the right iliac fossa on palpating the left iliac fossa. What is the name of the sign? So why don't you guys have a guess? Yeah, so that's correct. So it is Rosing sign. The first two are seen in cholecystitis, and these two, as we discussed earlier, external, as mentioned in the chat, are external manifestations of intra-abdominal bleeding or hematomas. So if this sign is positive, then which abdominal condition would you suspect? Yeah, so appendicitis is what you'd be suspecting if the sign is positive. And do you guys know of which particular point in the right iliac fossa would be the most tender if someone does have appendicitis? Okay. So yeah, so if you are suspecting appendicitis, then the McBurney's point is one that would be quite tender in someone with appendicitis, and it's basically 1/3 the distance from the aces to the umbilicus. So right there where the red dot is. Okay. Once you've done a light and a deep palpation of the 9 quadrants of the abdomen, you want to specifically palpate for certain organs. You start with the liver. And how we start this is you want to place your hand in the right iliac fossa by using the flat edge of your hand. So that's how it's supposed to look. So you want to place the right hand and the radial sides of the right index finger. So this is quite high up, but imagine this hand was in the right iliac fossa, which is your starting point. And that's how you want to place your hand when you're beginning the palpation of the liver. Then you request the patient to take a deep breath, and as they do, you begin palpation. So you move to the next location with each deep breath. So let's say you start from here, and then you want to move 1 to 2 centimeters with each deep breath, and work your way all the way up to the right costal margin, as mentioned here. So yeah, keep palpating, move 1 to 2 centimeters superiorly as they keep taking deep breaths towards the costal margin. As you get closer, you might be able to feel the liver edge tapping against your hand. If you do feel the liver edge tapping, try and see if you can examine the following aspects. So degree of extension from right costal margin, that just means is how much lower down can you feel the liver from the costal margin. If it's 1 to 2 centimeters, that can be normal, but if it's more than 2, then that would suggest the liver is enlarged, and there could be something else going on. You want to see if it's tender, so is there any pain when you're palpating for it? Consistency, that might be a tricky one to feel, but you can have a try and see if it's smooth or if it's nodular. If it is nodular, you're thinking something like a liver pathology like cirrhosis, and pulsatile, which would be very rare, but you always try and see if you can see, because pulsatile hepatomegaly is associated with tricuspid regurg. Can you guys think of any causes of hepatomegaly? So what do you guys think would cause an enlarged liver? Just shout out some answers. Yeah, that's great. Hepatitis. Yeah, that's good. Yeah, right. Heart failure codes. So in terms of enlarged liver, there are loads of causes that could cause it to be enlarged. So infections, one of the things you're thinking about, so hepatitis, malaria, infectious mononucleosis, malignancies are another thing. Hepatic congestion, so that could be right heart failure, uh, hepatic vein thrombosis, or hematological conditions, so like leukemias, lymphomas. So it is quite a few to remember. So maybe it's easier to remember the broad categories like infection and hematological, etc. But yeah, so once we palpated the liver, we're going to now move on to the spleen. It's the same palpation technique as discussed before, just a different endpoint. So you're again going to start at the right iliac fossa, and with each deep breath, you want to move superiorly, 1 to 2 centimeters, towards the left costal margin. The spleen is not palpable in healthy individuals, unlike the liver. And that brings me to my next question. What do you guys think would cause an enlarged spleen? Any guesses? Yeah, that was good. Hematological conditions, yeah. So think chronic myeloid leukemias, myelofibrosis, malaria could possibly could also cause it to be enlarged. Okay. So once you've done a light and deep palpation of the abdomen, you've had the palpation of the liver, you've palpated the spleen. You're now going to move on to palpating the aorta. So it's deep palpation using both hands superior to the umbilicus in the midline. That just means is that you want to place your hands, both your hands together on either side of the umbilicus. It's approximately at these red lines that I've put there. And that's how you'll place it. And you put good amount of pressure, sort of like when you were doing deep palpation. And when you do put that pressure, if you see that your hands move outwards, it could suggest an expansile mass. And that itself could indicate some thing like a AAA, which is an abdominal aortic aneurysm. But it's important to know that this is not a definitive test. It'll give you a good idea of what's going on, but you would require further investigations. Okay. And lastly, the last thing you want to feel for is the kidneys. So excuse my drawing of the hand, but it'll make sense in a minute. So you want to first place your left hand underneath the patient's back. So you place it below the ribs around the right or I wrote left or right flank. That's because you're going to do both sides, right and left. But for this explanation, let's say you're doing the left side first. So you place your left hand underneath the patient's back, and then you want to place your right hand on the anterior abdominal wall, so right below the costal margin. So you place this hand right below the left costal margin around the left flank. And that's how it would look like in real life. So the left hand is underneath and the right hand is on top of it. And then what you want to do is you want to push your fingers together. So the left hand moves upwards and then the right one moves downwards. And request the patient to take a deep breath and try to feel for the lower pole of the kidney. Don't focus too much on the lower pole. Just try to see when the patient takes a deep breath and you push your fingers together, can you feel something? And then you want to repeat the same thing on the opposite side. So you usually should not feel anything in healthy individuals, and it is quite hard to ballot the kidneys. If you do feel something, that's probably indicating an enlargement, which could be unilateral or bilateral. Can you guys think of any bilateral causes of the kidneys being enlarged? Yeah, so good. So polycystic kidney disease, amyloidosis, those are causes for kidneys to be enlarged on both sides. If it's one side, it might be a tumor, and that's something you might have on your differentials. But yeah, so now once you have the feel of the kidneys, that concludes the palpation section, and then you move on to percussion. So in terms of how do you actually percuss, you want to place your non-dominant hand firmly on the abdomen, and then with the middle finger of your other hand, which will be your dominant hand, you want to tap the middle phalanx of the middle finger. So sort of like you can see on this picture. And that's how it would look like when you do it actually on a patient. So place your non-dominant hand below, your dominant one on top, and tap the middle phalanx of the middle finger. If you guys, another question that you might have is, what does normal sound like and what would different? So it'd be a good idea to just have a practice on yourself, and what it sounds like to you would be normal. Okay. So in terms of percussion, the three places you want to percuss, you want to start with the liver. So start again in the right iliac fossa and work your way up to the costal margin. When you are palpating, you can note for the change in percussion notes from resonant to dull. So resonant would be your normal, and have a go at yourself and see what that sounds like. And as you're reaching towards the liver, it's going to change to dull. And that's like sort of an indication of how it might be. So it might be resonant all the way here, and then suddenly it goes dull. The other thing you want to palpate for is the spleen. So it's the same technique, but you're just going towards the left costal margin now. And then you also want to palpate the bladder. And for the bladder, you just have to start somewhere around the umbilicus and then work your way down. So just maybe twice you'll palpate, or thrice, it won't be long. In terms of percussion, there is another thing which is known as shifting dullness. So you want to, actually before that, do you guys know why we would try and do shifting dullness? Like, what are we trying to examine? Any ideas? Yeah, so extra fluid ascites. So we will only do this if we're suspecting that there's some extra fluid in the abdomen, and we want to examine it. How do we examine it? So you start from the umbilicus, and you start percussing from the umbilicus and you move towards the left flank of the patient. The point where you notice a change in the percussion notes, where it becomes dull, is the point you want to stop percussing. So let's say you start from this point, you're working your way, and then suddenly where this X is where the percussion note changes and becomes dull. So that's the point where you want to keep your hand there, don't move it, and you want to request the patient and ask them to roll towards you and stay in that position for 30 seconds. So while the patient has rolled and stayed in that session, in that position for 30 seconds, your hand has remained on the X and it doesn't move. And after 30 seconds, you want to again percuss the same area and see if the percussion note has changed. If it has changed, if it's resonant now, so that means that would indicate ascites because the dullness has shifted. And the reason why you tell the patient to roll towards you is just more for stability. So you'd have more control. Yeah, and yeah, throughout this whole 2 to 4, you'll keep your fingers at the same side. During an OSCE examination, due to time constraints, it's better to offer. So you can say, I would offer to perform shifting dullness if I suspect any ascites. If, of course, the station particularly requires you to do it, you can. But if you offer, that will let the examiner know that you know what you're doing. Okay. So after inspection, palpation, percussion, we come to the last step, which is auscultation. So you want to hear a few things. So first is bowel sounds. Use your diaphragm of your stethoscope to listen to any 2 locations on the abdomen. So usually around the umbilicus, you can do once on the right, once on the left, and have a listen. So normal bowel sounds are gurgling. And if you hear tinkling sounds, you could think, is it intestinal obstruction? If it's absent, again, you'd suspect an ileus or an obstruction. If you do see a patient and you think the bowel sounds are absent, you should listen to the tummy for at least 3 minutes to confirm this. In terms of OSCEs, it is unlikely that they'll give you someone with tinkling or absent bowel sounds, simply because that patient would probably have some pathology and would need to be treated. Normal bowel sounds, so have a go, use your stethoscope and have a listen to your tummy. And then you see like the normal gurgling sounds. The other thing you want to listen for is bruits. So you want to check for aortic bruits, and that would be 1 to 2 centimeters superior to the umbilicus. And you want to check for renal bruits. Both sides. So again, 1 to 2 centimeters superior to the umbilicus and slightly lateral to the midline. So that's how you'd assess for an aortic bruit. Use your diaphragm, keep it 1 to 2 centimeters superior to the umbilicus, and you only have to check in one spot. But when you're checking for renal artery bruits, because you have 2 kidneys, so you want to check both sides, again with your diaphragm. Okay. There are some additional bits in an abdominal examination that can give you extra information. So the first thing is having a look at the back. Do a quick inspection. So again, just see if you can see any abnormalities, so any scars, any rashes, any visible masses. The other thing you can check for is renal angle tenderness. So this technique might differ from different med schools and the way you're taught. But the way I was taught is you make a fist and then you gently tap below the ribs. While you're tapping, you want to make sure you look at the patient's face to see if they're in any pain, and as well as ask them, are you in any pain? So it's a very gentle tap that you do on both sides. The other thing you want to check for is there any sacral edema? And in the legs, you're particularly going to check for any pitting edema. So why do we want to check for pitting edema in a gastrointestinal exam? Any thoughts? Yeah, so it's a sign of hypoalbuminemia, so low albumin. So that's why you want to have a check pedal edema as well. Okay, so it's quite a bit to take in when you need to examine any system. The way I sort of break it down is I do the basics and then I go to inspection, palpation, percussion, auscultation, and then end it off with SBAR. And I usually think of IPA, so that's when I do examinations. So once I'm done with inspection, then I know, okay, there are 2 Ps to go. So I'll do palpation and then percussion. In terms of SBAR, so situation, so if you're an OSCE, the examiner will already know your name and role. You don't need to repeat it. But if it's a hospital setting or a GP, you would give patient details and give a brief 1 to 3 lines about what they've come in with. So Mr. Hex has presented with sudden onset abdominal pain. The background, is there any relevant medical problems? Have they had any hospital admissions, etc.? And then your assessment. So this is where you'll present your examination findings and what you found. If you've done any investigations, have they found anything? You can include that as well. And recommendations. So that's your next steps. What are you concerned about? If you're in like preclinical years, they may not expect you to give a very detailed next step. So you could just say you want senior review or this patient requires further investigations. However, if you are in clinical years, it's useful to know what your next step would be in terms of management. So would you do investigations? Would you admit them? Is there any particular kind of test you need to do? Right. So that's the abdominal examination. We'll do a quick run through rectal, which shouldn't take too long. So again, this is the same as abdominal. So you want to do hand hygiene and plus minus PPE. You want to introduce yourself, check patient details, explain the examination. It's important to warn the patient that this procedure can be uncomfortable so they know what to expect. And request a chaperone. And I've highlighted that because that's very important to do. Tell the patient that it's all right if you have a chaperone. You might also need to explain to them what is a chaperone and why you need to have it. And then you gather your equipment. So once you've done the steps till the chaperone, then tell the patient, okay, so you can undress now, and then in the meantime, I'm gonna go gather my equipment. Give me a shout when you're ready. So in terms of the equipment that you're gonna need a pair of gloves. You're going to be wearing an apron, some paper towels, and a lubricant. So inspection. So first thing you want to do is lie the bed flat. Ask the patient, we're gonna have to lie the bed flat. Is that all right with you? Okay, then request the patient to turn to the left side and then to ask them to bring their knees up towards their chest. And once they're in this position and they're comfortable, then request and ask for their permission again to lift the sheet so you can begin examining them. Okay. So that's sort of how it will look. Once you've taken permission, you lift the sheet and then you have a look at the area. So there are a few things that you're examining for. Can you guys have a guess at what A might be? Yeah, so A is an anal fissure. And what about B? Yeah, so B is an external hemorrhoid. So things to look out for when you're examining, doing a rectal examination is, are there any fistulas, any anal fissures, is there any bleeding from somewhere, any cuts or scars, any hemorrhoids, skin tags, skin excoriation, or any rashes. And you can also ask the patient to cough. That might make an internal hemorrhoid or a rectal prolapse more pronounced. Once you're done with inspection, you want to move on to the actual procedure. So lubricate your index finger. Warm the patient before inserting your finger. And then once you warm them, you want to insert your index finger gently. So here, and then here you've inserted your finger completely. Things that you're going to be checking in a rectal examination. So you want to rotate your finger 360 degrees, and that's just basically completing a full circle with your finger. During that time, you're seeing, can you feel any lumps? Can you feel any hard stool? Is it particularly painful for the patient in any area? The procedure will be uncomfortable, but is it pain that you wouldn't expect from this procedure? If it's a male patient, you want to palpate the prostate. And if you're palpating it, you want to particularly see the size, symmetry, and the texture of it. So if it's a normal prostate, it will usually be walnut sized. And you'd see a well-defined median sulcus. If they have some benign prostatic hypertrophy, then it would be an enlarged prostate, and your median sulcus would be quite deep when you're having a feel of it. If they do have something like a carcinoma, the surface itself, when you're feeling the prostate, it would feel quite irregular. You may not actually be able to differentiate the median sulcus. But yeah, so once you've done a 360 sweep, you've checked the prostate if it's a male patient. Lastly, you want to check the anal tone. So ask the patient to squeeze your finger with their buttocks. And it's usually nice to do that last, because right after that, you can remove your finger. And you're basically checking that because if there's any spinal cord injuries, etc., then they may not have good anal tone. So that would help you check that. Post procedure, so you remove your finger and then withdraw and inspect finger. And it's important to say that I'm withdrawing and now I'm inspecting the glove, inspecting my finger. Things you're looking out for: is there any blood? If there is, comment on whether it's fresh or if it's dark. Do you see any mucus? Do you see any stool? Following that, you can offer to wipe the excess lubricant. So if in your OSCE you have a simulated patient, you can ask the patient, would you prefer to wipe yourself or should I do it? Or would you like me to do it? And you can offer to wipe off the excess lubricant. Then recover the patient, offer any assistance, ask them, do you need any help with dressing up? If not, say this is the end of the procedure. Thank you very much for your time. Do you have any questions? And lastly, you want to basically dispose of all your waste in the clinical waste bin. Okay. And that's the end of the rectal examination. So I've put a case here, and that's just if you guys want to practice S-bar. So is anyone brave enough to have a go of it? So basically a 62-year-old female presents to ED with a 1-day history of sudden onset abdominal pain and nausea. On examining them, you notice that the abdomen slightly distended, generalized tenderness across the abdomen, worse in epigastric and suprapubic regions. Bowel sounds are tinkling. Rest of the examination is unremarkable. So, does anyone want to try and practice an S-bar? No, nobody has to. I won't pick anyone. Okay. That's fine. Yeah, so if you had to present this, you'd say situation is you have a 62-year-old female who's come in with a 1-day history of sudden onset abdominal pain and nausea. There's no relevant background history here, so you can say no relevant background history or medical conditions that you know of. On examining her, you notice that her abdomen slightly distended. She's got tenderness all across her abdomen, particularly worse in the epigastric and suprapubic regions. Her bowel sounds are tinkling, but the rest of the examination is unremarkable. Your recommendation is that this patient's quite unwell, so she requires further investigations, senior review. Depends on what stage you're at, depends on how detailed you can do your recommendation. Given this history, do you guys have any differentials in your mind? Are you thinking of any particular thing that could be going on? Yeah, that's good. Yeah, so it's a pretty good, prominent history for a bowel obstruction. So in your recommendation or your assessment bit, you can always say, I suspect this patient might have bowel obstruction. And that's why I'm recommending that we do her blood so we can do an abdominal x-ray. The things like this are always good to do, right? So that's the end of this session. Thank you very much for attending. I have put in a feedback form, and I really appreciate it if you guys could just fill it. It won't take long, but it would help us know what we can do better for the next sessions. The next session is an E2E assessment, so there will be a neurology case and a gastrointestinal case. And the resources are used at the end of the slide. And you can have a look at